And thank you so much, Professor Bronchard, for that wonderful lecture on COVID ARDS and ventilator strategies. So our first question comes from Dr. Luis Habana. Is the reason for the efficacy of the helmet device or even CPAP a result of better positive pressure titration, which lessens SILI, self-inflicted lung injury?
Well, thank you very much. Would say that we have different techniques which have been shown to reduce the intubation, the need for intubation. And this includes CPAP. This includes high flow, which, as you know, is able to deliver a small amount of positive pressure. And indeed, the helmet seems to be even better than traditional NIV. And all these techniques maintain some positive pressure, which seems to be very important in COVID. We don't know exactly, with helmet, what's interesting is that even if you use the same level of positive pressure compared to another technique, it seems that you maintain positive pressure during a long time, even during expiration. And it's possible that it may help to keep the lung open. To be really honest, we don't know exactly what's the mechanism at play, but the most important is to say it's really important to try to use these different techniques, maybe see individually in each patient what is the best tolerated, and try to avoid intubation. And it seems that maintaining positive pressure seems to be something important. Yeah.
Thank you so much, sir. So I one thing really caught my attention in your lecture, sir, was you have to try to avoid intubation just because of hypoxemia. So that's very actually hypoxemia in itself is actually pretty scary, especially for those clinicians who have very low tolerability in terms of hypoxemia, sir. So I would like to ask, how low can we go and how low can we tolerate hypoxemia just to avoid intubating the patient? For example, are we more tolerable for young patients to tolerate hypoxemia, or we should be more aggressive in terms of addressing the hypoxemia for elderly patients, sir? So what are your thoughts on that one?
That's very good point. Very, very good. So, when we talk about hypoxemia, there was one expedition to Mount Everest where they measured the arterial blood gas of people going very, very close to the summit of Mount Everest. That was crazy because they took a real arterial blood gas in the femoral artery on the top of the Mount Everest. So just to know what's the blood gas there. And they found, so it was very, physically trained people who went up very progressively. So they had a very high level of hemoglobin, and they were also hyperventilating considerably. So their PCO2 was around 10 millimeters of mercury. But the surprise was that their PaO2, so in the arterial gas, was around 20 to 25 millimeters of mercury. I don't know if they were completely safe in their head, but they looked okay, and and they were living very well. So it's just an example to show that we can have extreme values with relatively little consequence. I know it's not ICU patients, right? They are very well trained, and again, they have all these compensatory mechanism. But I would say you expect that with hypoxemia, the tissue will be suffering. However, if, for instance, you look for the lactate level, you need to reach very low level of hypoxemia to to see blood lactate going up and therefore suggesting that you start to have some tissue suffering from anaerobic metabolism. So I would say, your question said, should it depend on the type of patient and the comorbidities, etc.? My answer is yes. I think we should use a good clinical judgment, but I think the clinical tolerance of the patient, both in terms of respiration, work of breathing, but also mentation, lactate level, these are all important factors. And I would say a PaO2 of 50 will be well tolerated by many patients. I think we of course are very concerned because we know that if the PaO2 goes lower than that, it can be very quickly poorly tolerated. So you're absolutely right. It will depend on the individual patient, on the comorbidities. About the age, I don't know. I'm not sure whether age is a major factor, saying that we should not tolerate more hypoxemia. But I would say the clinical examination, the clinical tolerance, and maybe the organ function, including lactate, etc. If everything is fine, I would not push too much. If I see the renal function is not doing well, or there is also hemodynamic compromise associated, I would go very quickly for intubation. If not, I would try to tolerate and use all these different techniques. And one thing which has been remarkable for COVID is that, we have this technique of the self-proning. But in fact, the position of the patient sometimes makes a big difference. And sometimes it may be just that you, instead of having the patient sitting up, you put the patient down, you have a better oxygenation. So you have to try the best positioning. And again, base your clinical judgment on the clinical examination of the patient.
All right. Thank you so much. So that's very important. So we need always to look at the patient at the bedside, use our clinical eye and acumen so that we know which patients to intubate early and which patient we can tolerate a little bit more so that we cannot also go ill effects of being intubated. So the second question, sir, is from Dr. Laura Horlock. So she said, she's asking, do you think the barotrauma we saw so much more of in Delta wave was Macklin effect or because of the Delta virus itself? Like, did we wait too long to intubate because we recognized we intubated too early in the first waves?
I think that's a good point. That's what I feel, but I've no definitive evidence for that. But I think to have this Macklin effect, you need to have both injury in the lung and a mechanical stretch on the lung. So, and all the patients I've seen who have been intubated after having developed a barotrauma, they had a catastrophic mechanics on the ventilator. So I'm sure this is related to a very poor respiratory mechanics situation. However, we don't have evidence that having intubation earlier would have prevented that. I'm just saying when we see this patient at this stage, we can be sure this is very late and this is very concerning. And sometimes the patients, they feel it's very hard, but they're also very scared about intubation and they try to delay things a lot. In the very initial stage, I know in China, they wanted to intubate the patient very late. And they had a lot of these patients with very poor mechanics. So I'm sure there is a compromise to find between too early, which is certainly not good, and too late, which may happen. But that's really complicated.
So another question from Dr. Hanan. Do you think that the ARDS due to COVID is different for the different subtypes? Because we noticed that during the Delta variant caused more severe disease and pneumothoraces, sir.
What we see with the Omicron is that clearly the data show there is less patients going to the ICU. However, it's very difficult to compare because much more people are vaccinated. We now use a lot of medications. So this may be the explanation why there are much less patients coming to the ICU. However, when you look at Omicron patients in the ICU, so those who have been admitted in the ICU, I think their outcome is very similar to the Delta variant patients admitted in the ICU. So there may be less patients for different reasons coming to the ICU, but once they are in the ICU, it's about the same outcome. So I think the differences are mostly related to the fact that there is much more vaccine, plus people who already get infected, and we have a lot of medications which can decrease the severity of the disease. I'm not sure the severity by itself, or for the same population, is different.
All right, thank you, sir. So very important message: get yourselves vaccinated, because the vaccination will actually really reduce your hospital stay in the event that you become hospitalized due to COVID. Or else, if you're not vaccinated, you just have to go through the same rigorous and stormy course. So that's very good point, sir. Another question.
Just to say, the patients we see in the ICU are either patients non-vaccinated or patients vaccinated but who have immunosuppression, right? Like the transplant patients from kidney or lung, Yes, sir.